abdominal pain and gallstones. I think I'll pass it over to you. It's a really neat Dutch trial, as only the Dutch seem to be able to do, not only the trials up front, but also the follow-up. And it certainly sparks food for thought, I think, to a lot of us, and food for thought in my practice as well. So thank you, Kelly.
Thanks so much. And for those who don't know me, I'm Kelly Vogt. I'm a surgeon in London and one of the EBRS executives. It's my real pleasure. We have three amazing panelists tonight to introduce our first panelist to give us the methodologic review. Dr. James Byrne is a trauma and acute care surgeon at Vancouver General Hospital and an assistant professor in the Department of Surgery at UBC. He initially trained at Trinity College in Dublin and then completed a general surgery residency at the University of Toronto, where he concurrently completed a PhD in clinical epidemiology. After residency, he completed fellowship in trauma surgery and surgical critical care at the University of Pennsylvania. He practiced as a trauma surgeon and intensivist at Johns Hopkins Hospital in Baltimore before we were lucky enough to say he moved back to Vancouver, his hometown. Proudly Canadian yet again. I will turn it over to you, James, for your methods review.
Thanks very much, Kelly. And it is certainly me who's lucky to be here. A moment as I find my screen. All right, can you guys all see my the screen or the PowerPoint that I'm sharing?
I can't yet.
Oh, okay.
That's
there we go.
It's loading now.
More promising.
You're good. Yeah, you're good.
Awesome, great. Okay, yeah, so my name's James Byrne. Thanks very much for including me in this really interesting sort of review of an interesting paper. So I'm going to discuss or review the methodology that was used in this 5-year follow-up of the secure RCT, which was evaluating restrictive strategy versus usual care for cholecystectomy in patients with abdominal pain and gallstones. So first, I thought it would be helpful to review the rationale for why this new study was done. So the 1-year follow-up results from the secure trial were actually published in the Lancet in 2019. And they, as I describe more about what this means, it compared a restrictive strategy to usual care for selecting patients to undergo cholecystectomy. What they found was that both arms resulted in what they called a suboptimal reduction in pain in both groups. So interesting, both groups sort of had a comparable degree of number of people that were pain-free, which is only in the range of 56 versus 60%. It did not meet a threshold for non-inferiority. And really the only difference was a small reduction in the number of cholecystectomies that were performed in the restrictive group. But there's always the possibility that a 1-year time horizon is too short to show important differences in important long-term outcomes. And there's the potential for effects due to crossover from the non-operative to surgical treatment. And then there's also the potential for later biliary complications. And so they'd always planned on performing this 5-year follow-up study. So the study design of the current study is a multi-center randomized parallel arm non-inferiority study. So this was performed at 24 academic and non-academic hospitals in the Netherlands. And the outcomes were taken at 5 years from initial randomization, specifically comparing, again, the restrictive strategy, which I'll describe, to usual care for undertaking cholecystectomy. So the patients that they included were adults with symptomatic cholelithiasis. And what they defined this as were patients with a history of abdominal pain who had an ultrasound that demonstrated gallstones. And of note, in the original study, they mentioned that this also included patients that had sludge, who were referred to a surgical outpatient clinic. So basically, the typical patient that we see in our surgical clinics. Patients with a history of complicated gallstone disease were excluded. So these weren't patients that had already had cholecystitis or pancreatitis or anything like that. Patients with cancer or an expected shorter lifespan were excluded. Patients with significant morbidity, cognitive impairment, or language or insufficient language proficiency to be consented, and also pregnant patients were excluded. So what were the treatment groups and how were they allocated? And so at the very first office visits, patients would come in and complete a digital triage instrument. And so the triage instrument included 5 pre-specified selection criteria. These were severe pain attacks, pain lasting 15 to 30 minutes or longer, pain located in the epigastrium or right upper quadrant, pain radiating to the back, and then positive pain response to simple analgesics. So the way that they justify these 5 criteria were the first 3 are the Rome 3 definition for biliary colic, but including the radiating to the back and positive pain response to analgesics increases the sensitivity for pain due to gallstones. And so once patients had created this digital triage instrument answering these questions, they were then allocated to usual care or the restrictive strategy. So in the usual care arm, patients received the standard care at the participating center. So this is literally whatever the center would normally do with patients like this. And so surgery was at the discretion of the surgeon in a shared decision-making model with the patients. Basically, look at the evidence, decide whether or not they think it's gallstones, and then make a plan with the patient. The restrictive strategy arm, in the restrictive strategy arm, patients who fulfilled all 5 triage criteria were advised to undergo cholecystectomy. So a little bit more directed here. So basically, patients that checked the box on all 5 of those criteria were basically advised to have a surgery. Patients that didn't fulfill the selection or the criteria were selected for conservative or non-operative management, and then underwent further workup for looking for alternate diagnoses. So basically, like the bar for advising patients to have surgery was a little bit better defined and perhaps a slightly higher, threshold than a little bit based on judgment. In terms of how randomization and actual allocation to these arms was done, and so all patients were consented and randomized prior to their first hospital visit. Randomization was done in a 1-to-1 fashion between the usual care and restrictive strategy arms. And this was done using an online randomization software that was accessed via a web-based application. Notably, randomization was stratified by certain hospital characteristics, sex, and BMI. Stratifying by these is basically means that randomization was performed separately within these different categories to ensure that the distribution of patients was basically properly randomized within each of these different categories. And then finally, treatment allocation was revealed to both the patient and the physician after they completed the triage tool at their first office visit. So notable that both the patient and physician learned what they were facing together. So the primary outcome was a non-inferiority endpoint, which was defined as the number of patients that were pain-free. And so pain-free was defined in a couple of different ways. So the way that this was done in the initial study and also at the 5-year follow-up was using this thing called the Isbicki pain score. And so they defined pain-free as an IPS of less than or equal to 10. And so the Isbicki pain score, it's a validated pain score that was originally designed for chronic pancreatitis. It has specific questions related to the frequency of pain, intensity, how much painkillers you're using, and your inability to work. It ranges from 0 to 100, and so 10 is clearly on the lower end, and it's easy to complete within 3 minutes. Then they also use the visual analog scale for a pain score of less than or equal to 4. So the visual analog scale is this. It's literally just show me where you are in terms of your pain. So just notable here, the Isbicki pain score actually includes the visual analog scale in it, but only in this 5-year follow-up did they define the visual analog scale as its own endpoint. So this wasn't done in the first one. Secondary endpoints included the number of cholecystectomies that patients had, gallstone-related complications, surgery-related complications, and classified as sort of mild, moderate to severe using Clavie and Dindo. Patient-reported satisfaction with the treatment on a scale of 1 to 10. And then also, interestingly, other measures of like healthcare utilization, which were, visits to office or emergency department for pain, further imaging studies, endoscopies, and also the diagnosis of a functional GI disorder. very important for this 5-year follow-up. So follow-up was captured in three different ways. So at the 5-year mark, after being randomized, patients received a telephone call and a structured interview. And so they were asked basically questions that ascertained all of the outcomes that I mentioned before. So questions related to, do you have persistent abdominal pain? What is your pain intensity? Did you have symptom relief? And then the patient treatment satisfaction. They also received a questionnaire by email, which included a lot of the same things, but some more detailed questions related to abdominal symptoms. And then data was also collected from the health records. And so this was where I believe that they gathered a lot of their information related to whether patients had cholecystectomy, whether or not they had problems related to gallstone-related complications, and other measures of healthcare utilization. And so before I go into the statistical analysis, I thought it would be helpful to kind of briefly summarize a little bit about non-inferiority, because even if we all kind of heard of this before, if you don't think about it for 2 days, you quickly forget it, or at least I do. And so basically, non-inferiority means that we aren't interested in whether or not this new intervention or restrictive strategy is better, just whether it's good enough or comparable to the usual care. So in this study, we're asking if the restrictive strategy is good enough. Like basically, can we perform less cholecystectomies and achieve a comparable enough outcome compared to usual care? And so on this little visual scale here, 0 is whatever the rate of pain-free patients is for whatever usual care achieves. If the restrictive strategy achieves a lower proportion of patients that are pain-free, that's worse. And if it achieves more patients that are pain-free, that's better. Importantly, in a non-inferiority study, we even accept that a new treatment might actually be a little bit worse, but we have to define, based on our clinical judgment, how much worse is acceptable. And so this is what we define as the non-inferiority margin. And so possible sort of outcomes from this are, say, like if this point estimate is the point estimate for the proportion of patients that are pain-free after the restrictive strategy, well, this is clearly better. We would even accept if the restrictive strategy is slightly worse, but that the confidence interval doesn't overlap the non-inferiority margin. But if the restrictive strategy is worse, or the margin of error, specifically the sort of one-sided 95% confidence interval, overlaps that non-inferiority margin, we can't say it's non-inferior. So this little visual with the point estimate and the confidence interval overlapping the non-inferiority margin is kind of what it's all about. And so this was relevant to the sample size calculation. And so some assumptions that they make, which you can decide whether or not it's legit, is that the proportion of pain-free patients in the restrictive strategy will at least equal that in the usual care. That the maximum proportion of patients that will be pain-free after usual care is 80%. They defined that non-inferiority margin as 5%, and used one-sided Z-test with a power of 80% and a significance level of 5% to come to the conclusion that they needed 1,038 patients in their study to be adequately powered. So in terms of how they analyzed the primary endpoint, which was the number of patients that were pain-free, they did this by comparing both the Isbicki pain score and the visual analog scale using one-tailed chi-squared tests, because they're basically, you know, the percentage of patients, or the frequency of patients that are pain-free. And they use the non-inferiority defined as the lower limit of the one-sided 95% confidence interval falling within the 5% margin. Within meaning like overlapping, like in that visual. And what I thought was interesting was they examined this in 2 ways. And so they did this both using an intention to treat and per protocol analysis. And so these are 2 ways of analyzing the data that ultimately define which patients are included in their analysis. So in the intention to treat analysis, every patient is analyzed in the group that they were allocated. So like the cliche here is once randomized, always analyzed. And the benefit here is that the effect of randomization is maintained. And so all of the known and unknown factors that that are the reason we randomize patients are kind of remain true between the two groups. It's more generalizable because it sort of includes the unpredictable way that patients behave. Patients don't always maybe accept the treatment that they're allocated, and so it's a little bit more real world. But because of all of this, sometimes it might underestimate an effect. So, but in the per protocol method, it only analyzes patients who strictly adhered to the protocol that they were assigned to. And so what this meant was in the usual care arm, patients that were planned for surgery but didn't have surgery were excluded. And in the restrictive care arm, patients that met the criteria and we told them to have surgery but they didn't were excluded. And conversely, those that didn't meet the criteria but said, I want surgery, were excluded. And so the per protocol approach isolates patients that actually only got the intended treatment. And so it's a little bit more true to say, like, what's the actual treatment effect? But it actually tends to overestimate the treatment effects because patients don't, like, the population doesn't all behave that way. And so it doesn't take into consideration patients who broke protocol and that sort of thing. The secondary endpoints were basically all just tested using normal tests. So chi-squared for dichotomous data, t-test and Mann-Whitney U-test for continuous data. And these were tested in a superiority fashion, so just the normal tests. They didn't impute missing data because the response rate at the 5-year follow-up was greater than 80%. And so ultimately, patients with missing data, I believe, were excluded. So just my last sort of almost summary slide. Some of the positives of the study, I think, are that it's a very interesting rationale, and I think a very high impact question because this is one of the most common scenarios that we face in our clinics, and it's a very pragmatic study design. I think the outcomes were important and well defined and easy to measure, and it had a solid and predefined analytic plan. But just to kind of like throw at a couple of issues, which is something to consider when we're now going to talk about the results and how to interpret it, is there are some sources of bias. And in terms of randomization, so problems with randomizations can occur. So I thought their approach to it seemed totally pretty much airtight. But as we'll see, there was a potential problem resulting in an imbalance in some of the patient characteristics that were actually in the two groups. So I think perhaps we'll talk about that. There's also potential for deviations from intended treatment. And so I think that this is common in surgery because, we can think of all the ways that we want to really put patients in one group or another, but then patients don't always kind of do what is best for a study. And so one of the things that I thought was interesting was that patients were aware of their treatment group. And so, if you were told, okay, you have gallstone pain, but now we're putting you in a restrictive group, I don't know how that would affect you versus saying, okay, now we're going to do the usual thing. And so I wonder if it wasn't necessary to straight up tell patients, what we're going to do now if they were already consented. I don't know if that's an unethical thought. And then there is the potential for contamination, which is sort of something I thought was interesting. If you're a surgeon and you're part of the study and you're treating some patients in a restrictive arm where you're giving them this 5-point triage questionnaire, are you then going to actually start thinking about what your threshold for surgery is a little bit differently in patients you're now told to treat usually? So, basically it's the same practitioners, and so is it going to affect how you treat the usual care arm? And then lastly, because it's a 5-year follow-up, the 5-year follow-up might not achieve the defined sample size, and so there's a little bit of a risk of type 2 error. So I'll stop there and look forward to seeing the results and discussing it.
Thanks so much, James. That's awesome review of some of the key methodologic considerations. I'm going to turn it over next to Dr. Bertens, and as she's getting her screen on, I will share with everybody just a reminder, please use the chat for any questions. There will definitely be time for some discussion at the end. We'd love to hear your thoughts and your thoughts for the panelists. It gives me great pleasure to introduce Dr. Kim Bertens. She is an assistant professor of surgery at the University of Ottawa and the section head of hepatobiliary surgery at the Ottawa Hospital, as well as the site chief of general surgery at the general campus. We were thrilled to have her complete her residency in general surgery with us here at Western, followed by a fellowship in HPB surgery at Virginia Mason Medical Center in Seattle, Washington. She holds a Master of Public Health with a focus on quantitative methods from the Harvard School of Public Health, and she's here to give us our perspectives on the results and the interpretation of this trial in clinical practice. Thanks, Kip.
Thanks, Kelly. So this is not going to be quite as focused on the methodology, although I didn't know exactly how much detail James would go into. So I may be repeating a bit of what he talks about, so I'm sorry about that, and I'll try to skip through that faster. So today I was just going to give a little bit of a brief overview of gallstones and biliary colic. I know the vast majority of the people on the call are well aware of these things, but I also was going to go through the SECURE trial a little bit and talk a little bit about how they use these predictive factors. And then I also wanted to draw attention to what I think is probably a more interesting study, which is the Seagull study that was also recently published. And then just some takeaway points of how I think this could be used in practice. So just a little bit of background. So gallstones, when we look at North American and European data, lifetime prevalence is somewhere around 10 to 15% and tends to be a little bit higher in North American and European population. So this is looking at US data and also large cohorts from Italy as well. So of patients that have ultrasound confirmed gallstones, about 80% of those patients will actually be completely asymptomatic from it. And if those patients are followed forward in time, somewhere between 10 and 25% of those patients will develop symptoms. Interestingly, patients are more likely to develop symptoms if they're told that they have gallstones than if they're not told. But just to be aware that many patients with gallstones don't have any symptoms at all. And it's estimated that about 2 to 4% of these patients would become symptomatic per year. Also important is when we follow patients that have had one episode of what is believed to be biliary colic, about half of those will have another episode of biliary colic within the same year, which means that half do not. And about 1 to 2% will develop complicated gallstones per year. And so that means patients that develop acute cholecystitis, pancreatitis, choledocholithiasis. So as we all know, biliary colic is felt to be caused by transient obstruction of the cystic duct by stones or sometimes sludge. The pain comes on when there's contraction of the gallbladder after the release of CCK. It tends to be sudden onset and it increases in intensity and then reaches the plateau, typically lasting somewhere around 1 to 5 hours. The pain is usually described as being moderate to severe pain, can have associated nausea, very common, and sometimes even vomiting. And it often occurs soon after meals, more commonly after fatty meals, and more commonly in the evening. So why this study is really done is the issue to do with persistent post-cholecystectomy symptoms. And this was previously called post-cholecystectomy syndrome, although that term has kind of been moved away from. But when we look at systematic reviews, it's estimated that anywhere between 10 and 40% of patients will have persistent pain after a cholecystectomy or persistent abdominal pain. When that gets looked in a little bit more detail, about 20% or 1 in 5 patients that have their gallbladder removed will continue to have pain similar to what they experienced preoperatively. And one can only assume that that means that the pain that they were having preoperatively was not biliary colic, because you should not be able to have continued biliary colic type pain in the absence of a gallbladder. In most situations, of course, developing stones in the bile duct or something could change that. But for the majority of patients, you really shouldn't be able to have that ongoing pain without a gallbladder. About 14% of patients will develop de novo abdominal symptoms, which may or may not be related to the gallbladder. But importantly, these often involve things such as dyspepsia, heartburn, nausea and vomiting, or diarrhea and flatulence. And it's quite possible that there's mechanisms that change digestion following a cholecystectomy that are actually leading to these patients getting new symptoms. So moving on to the SECURE trial. So as James already brought attention to, this is a 5-year follow-up study of the study that was published in the Lancet in 2019, done by the Dutch group. And what is the outcome that we're really looking to avoid here? Like, why was this study done at all? And essentially, it's looking to address the ineffective cholecystectomy, meaning patients that have ongoing abdominal pain after cholecystectomy. And this is why the researchers chose this as their primary outcome. So just looking at the overall population, and again, I'm not going to go into this in a great amount of detail because James already touched upon this, but in the yellow box, you can see that it was a wide range of ages of patients with gallstones, and they do mention in the initial study that sludge was also included. They were patients that had not had a previous history of complicated gallstones. The usual care group is defined as cholecystectomy offered at the discretion of the surgeon, and then we have the restrictive care group that they came up with these 5 different things, and the patients had to have each of the 5 for them to be offered cholecystectomy in that group. However, it's in my mind a little bit of a misnomer to call this restrictive versus usual care, because presumably a surgeon's already practicing restrictive care, and in most healthcare settings, surgeons aren't offering cholecystectomies to every patient with gallstones. So presumably the surgeon already has some sort of process in the clinical history by which they're trying to decide whether or not this abdominal pain can be attributable to the gallstones. So as James mentioned, they developed these restrictive criteria following a systematic review. Important to know that these are not validated in any sort of way. They used the Rome 3 criteria, and then they added on these 2 based on findings in systematic reviews. One of my biggest pet peeves of the Rome criteria is it says that the pain has to be lasting longer than 15 to 30 minutes. And I feel like the 30 part is very redundant there, but pain greater than 15 minutes, acute severe abdominal pain, and located in the right upper quadrant. And as James mentioned, they added radiating to the back and a positive response to simple analgesia. Looking at their study, though, interestingly, the use of pain medications in the triage survey that they gave, they actually asked more questions than just these 5 questions. And they did ask how many patients had used pain medication. And in the usual care group, about 48% had, and in the restrictive care group, 51% had. So looking at this, nearly half of the patients would never have made all 5 criteria if they had never tried pain medication. And in fact, in the restrictive group, only 38% of the patients met all 5 criteria. So one thing that, when I'm going through these criteria that they use, one thing that I thought was really interesting and something that I focus a lot on in my clinical history when I'm taking a history from patients is, any relation to food or any types of food that seem to bring it on. And that, of course, wasn't part of their 5 points at all. They did ask in the triage criteria if the patient had intolerance to fatty food, but it was not described as pain. And in the usual care group, 45% said they had intolerance to fatty foods, whereas 47% said they had intolerance to fatty foods in the restrictive care group. But noting that intolerance to fatty food does not necessarily equal a history that's consistent with biliary colic. Someone with pancreatic insufficiency, for example, will have intolerance to fatty foods, but that doesn't mean that they're necessarily getting symptoms that sound like biliary colic. So what are they really studying here? And I think that was the big question when I was sort of looking at these 2 groups and looking at this study, like, what are we really trying to see here? And, if we're going to make the assumption that pain that's caused by biliary colic should be resolved by removing the gallbladder, then really is this study actually asking if the 5-question criteria is non-inferior at picking patients that have pain attributable to their gallstones than a surgeon's clinical history? So I won't go into great detail here because James already gave us some of the results, but I had the results both from the Lancet paper as well from the 5-year follow-up paper. And so we can see that the patients that are pain-free at 1 year and the patients that are pain-free at 5 years are really not much different. But interestingly, when we look at this, the number of patients that went on to have cholecystectomy are also not very different at all. So at 1 year, 75% in the usual care group had their gallbladder out, and at 1 year in the restrictive care, 68% had. And in the 5-year follow-up, it was 82% and 73%. So the first question that we have to ask ourselves, if only 38% met all 5 criteria in the restrictive group, how were 73% of them ending up getting their gallbladder out? And I think part of this is that there's a lot of non-compliance to the treatment protocol. And why is this? So perhaps the outcomes look very similar because perhaps the 2 study groups are pretty much the same. So if we look at the fact that 30% in the restrictive group didn't adhere to the prescribed protocol, the majority of those were patients that were not supposed to have their gallbladder out that had their gallbladder out. And more than half of those were patients where the surgeon recommended surgery when all 5 criteria were not met. And then the other thing that I wanted to bring forth is, as I mentioned earlier, surgeons are already practicing restrictive care in most situations. It's very rare that somebody would have a clinical practice where every patient with a gallstone is offered cholecystectomy. So really what we're doing during that clinic visit is trying to decide whether or not the abdominal pain is truly biliary colic. The other thing to mention, and James sort of touched on this too, is that the surgeons that were participating knew the 5 criteria, and therefore those criteria for offering surgery likely influenced whether or not they offered surgery to those patients in their usual care group as well. So then looking at the predictive factors, or what they chose to look at for their 5 questionnaire, when we look at symptoms that are predictive of pain relief with cholecystectomy, it's important to mention that their restrictive criteria were in no way validated. So they came up with those, but they were not validated. And in fact, when you look to the literature, there's a variety of different things that are brought forth. And there is no accepted symptom complex for symptomatic gallstones that's been described or validated. In a large cohort study of 29,000 patients in Italy, the features that were most likely to be predictive of pain relief with cholecystectomy. So basically what we're looking at here are, if patients have these symptoms, they're likely to have relief of their pain when their gallbladder is taken out, meaning that these symptoms likely mean that the abdominal pain is biliary colic. And so in this Italian study, they showed that epigastric or right hypochondrium pain, radiation to the shoulder, pain and absence of heartburn or unrelieved by a bowel movement, and intolerance to fried or fatty foods were more likely to be relieved with their pain. There was another study done in the US population. It was over 1,000 patients, mostly out of Mayo Clinic, and they showed that patients that have less than 1 episode of pain a month, patients that have had pain for less than a year, patients whose pain lasts from 30 minutes to 24 hours, that comes on at night, and that severity is greater than 5 out of 10 are more likely to have pain relief with cholecystectomy. And then in fact, in the SECURE trial, in true Dutch fashion, they went on to publish many different papers based on this cohort of patients, but they actually went back and analyzed the patients in the SECURE trial and looked for what factors were predictive of patients having pain relief with a cholecystectomy. And they found that increased age, no previous abdominal surgery, increased visual analog score, or basically increased pain severity, radiation to the back, reduction with simple analgesias, and nausea with the absence of GERD were most predictive. So all that to say is the things that they chose to put in their restrictive group were by no means validated, and really they could have chosen many different things to put in there. And then I just wanted to bring a little bit of attention to this Seagull study that was published in the Health Technology Assessment done in the UK system. So this was a randomized control randomized control trial of 430 patients in the UK. And basically what they looked at is they had patients where they were attributing the patient's pain to gallstones. So a little bit of a different patient population. It wasn't just abdominal pain. It was truly patients that they felt had biliary colic. And those patients were randomized 1-to-1 to lap chole versus observation with conservative management. So basically some dietary recommendations that were made for the patients. It was a very interesting study, and part of the validation for doing this study was indicating how much of the surgical budget is spent on cholecystectomy in the United Kingdom. So how much of that NHS budget is actually used towards cholecystectomy, and do all patients that have biliary colic require a cholecystectomy? So this study was actually started in 2019. So of course it was affected a little bit by the COVID pandemic in that initially it was meant to be an 18-month follow-up period, thinking that most of those patients would have had their gallbladder out by then. But because surgical wait times across the globe grind to a halt, they actually did a protocol amendment and followed these patients out to 2 years. And interestingly, in this group, you can see that there actually is a big difference in the percentage of patients that had a cholecystectomy, unlike the SECURE trial. So in the observation group, only 30% of patients had a cholecystectomy, although 7% were still waiting on a wait list to have their gallbladder out. And in the lap-chole group, 71% of them had had surgery, and there were still approximately 7% that were waiting on a wait list as well. At 2 years, they didn't see any difference in quality of life, in complications, or in need for further treatment. But they did see that there was a slight difference in condition-specific quality of life, and persistent symptom score favored cholecystectomy. And the difference is they did not use the Uzbeki. They actually used the Otago gallstone specific questionnaire. So it was the pain questions that were being asked were very specific to gallbladder type pain. And what they found in this short-term observation, that conservative management was actually found to be cost-effective in these patients, but they do recognize that the long-term follow-up has not yet been done. And so it's hard to comment on long-term cost-effectiveness because we don't know how many of these patients will eventually go to have their gallbladder out. So my takeaway points from going through these trials in the literature and how I would deal with this in my practice, I think that cholecystectomy remains a good treatment for biliary colic. But conservative or observation may be appropriate for those with a low burden of symptoms. So perhaps we really shouldn't be consenting every patient after their first episode of biliary colic to a cholecystectomy. I think the other thing that we have to take away from the SECURE trial is that cholecystectomy is not a good treatment for abdominal pain. And we also know from cohort studies that there's a higher prevalence of functional dyspepsia and IBS in patients that also have gallstones. And I think that cholecystectomy should be avoided in patients that are having symptoms that are atypical of gallstones. And that's what I've got.
Thanks for an awesome review, Kim. We're going to turn it over to Dr. Gregg next for his perspective. And a reminder to the audience, please put your questions or comments in the chat so we can address them. It's my pleasure to introduce our last panelist, Dr. Sean Gregg. Dr. Gregg was raised in rural Alberta. His residency in general surgery was completed at the University of Calgary, and from there he began a diverse surgical practice before returning to Calgary for subspecialty training in liver and pancreatic surgery. He continues to hold an academic appointment with the University of Calgary, and his current practice focuses on liver and pancreas oncology, upper GI disease, and venous insufficiency. Thanks for joining us, Sean.
Thanks, Kelly. Can you hear me okay?
Yeah, you're great.
Super. James gave like a wonderful, easy to follow outline of the methodology, and then Kim proceeded by adding a lot of detail and a really useful critique of some of the nuance in the paper, and then some of the relevant papers that add a little bit more detail. I'm sort of thinking of my role here as how do I take this to the clinic? How am I going to apply this to patients? I'd say Kim also added a slide there that I think is useful and relevant. But for me, I think the key takeaway points are not even really necessarily what they were intending to demonstrate. But along the way, some key takeaways would be after 5 years, there wasn't an increase in complications with a restrictive strategy. So maybe it didn't save a lot of surgeries, maybe it didn't save a lot of money, but certainly when you're having a conversation with a patient, I think it's fair to share that it's safe to wait. If there is some equivalency about the diagnosis or their symptoms don't justify a surgery, even if you think it's biliary colic, it's very reasonable to wait and follow along with them, connect with them in 6 months or a year, or ask for a re-referral if their symptoms persist. Because I do think a lot of patients, that's their key concern, is that their problem will get worse and then they'll have a complication and a problem much worse than what they brought with them to clinic. The second consideration, of course, that doesn't necessarily come up in the literature, but maybe was reflected in the British study as well, is patients are often quite keen to get treatment when they have a doctor in front of them. And part of that is just reflective of access issues. And they are scared that they're going to be turned away and say, no, it's safe to wait. But they're going to have 5, 6, 7 attacks before they can get treatment again. And so I think they're quite motivated to get treatment when they have the opportunity, or at least be put on the list. Sometimes for those people, I know my list is a year or more, I'll put them on my list, tell them that it's better to be on my list because it's easier to cancel than get put on my list again. And so for those people, I might put them on my list and then still follow up in 6 months and see if they still need to be on my list. And I think the last takeaway that I'm going to take to clinic tomorrow with me is I should be talking a lot more about non-resolution of pain, even in patients that have a pretty clear-cut case of biliary colic. Maybe all 5 criteria are met, even if they would be included in my non-restrictive group. They still had a fairly high rate of non-resolution of pain. And I don't think I've been having that conversation with my patients. Certainly I do if there's some doubt about the diagnosis or there's a broader differential. Everything else has been ruled out and we're choosing to proceed with laparoscopic cholecystectomy. I would certainly talk about non-resolution of pain as a risk, but I don't think I bring it up when I myself feel so confident about the diagnosis. But looking at those 5-year outcomes, I probably should be addressing that more directly. Kelly, those are my key thoughts. I didn't have any slides.
No, that's awesome. I think that's great. And I think between the 3 of you, what a great coverage of this paper and some really awesome points that were raised. We might get our panelists to turn their cameras on and we'll chat with you guys about some of the questions that have come in, a few in the chat, a few to my personal text, and I'm sure Chad's got 1 or 2 as well to add in. So, I think I'm going to pick up a little bit on your last point and maybe ask our other panelist, Sean, when you're consenting a patient for cholecystectomy, are you talking to them about non-resolution of symptoms outside the context of the patient that you actually probably don't believe you're taking their gallbladder out for a legitimate reason? The patient who's been in your office 5 times and says, just take my gallbladder out because I have gallstones. Is that part of your routine conversation, Kim?
So I do routinely bring up issues with symptoms post-cholecystectomy, diarrhea, flatulence. So I do bring that up. I quoted at 10% with the vast majority having resolution of symptoms over the course of a few months after cholecystectomy. But in reviewing this data, I suspect I'm actually quoting that too low, to be honest. So that is something I do specifically bring up. As for non-resolution of abdominal pain, I like you, Kelly, do not typically bring that up unless I have doubts about the diagnosis of biliary colic. So there's times where I won't offer a cholecystectomy because I believe that it absolutely isn't the gallbladder, and I worry that actually it's going to leave them in a worse place when I have a sort of a flavor of it being more of a functional abdominal pain. I really worry that a cholecystectomy might worsen that. But there's times where I tell a patient, I really don't know, like it might be biliary colic with some slightly atypical symptoms, it may not. Those patients, I will say, it's maybe 50-50 that this is going to make your pain better, or if I think it's higher or lower. But in those patients where I think it's slam dunk biliary colic, I don't talk about the other than post cholecystectomy symptoms, I don't talk about the non-resolution of pain, and perhaps I should be.
How about you, James?
Yeah, I'm pretty hedgy, so I really like what Kim describes. So I think I definitely raise the possibility of ongoing pain or post cholecystectomy symptoms in pretty much every patient, and the degree to which I titrate that up varies on the degree of uncertainty as to whether or not something else is going on. But
that's awesome. One of the comments references the frequency of nausea and vomiting associated with biliary colic. And the specific question was, why wouldn't they have included that as a predictive criterion or as part of their decision making in terms of whether or not they would offer cholecystectomy? Kim, you touched on this a bit, And you also touched on kind of the key symptoms for you. Is there anything else for you guys that you took from this trial to say, if patient presents with this, that's gonna sway me one way or the other? And I'll add my bias into this question. I would have loved it in the methods of this paper if they had asked the surgeons in advance, do you think this will improve the patient's pain? Particularly in the ones that they were going to operate on. I think that would have been a really cool methodological change to this paper and my bias, obviously with my surgeon hat on, is that I think we probably would have done as well, if not better, than the criterion they put forward. But I'll open up to the panel for your thoughts on that.
Yeah, I think for me, I'm not going to say I'll never call something biliary colic if there's no food relation, but to me, that is like the number one question I ask. It's like what I harp with the medical students. So the fact that that wasn't part of it at all seemed a little odd to me. And then the duration of pain, like to me, biliary colic really is episodic. Like it means that you go back to pain-free in between, and these episodes should be coming relatively infrequently. I mean, we all know there's people with crescendo biliary colic or that sort of thing, but they're usually people that have had a building of their symptoms over a course of a few weeks. They're not somebody that's been having daily symptoms going on for a year. Like that's not biliary colic. So to me, the episodic nature of it, which is not really captured in that five questionnaire, and the relation to food, if any, is important. I think the other thing I think about the trial that would have been really nice is if like they asked specific questions relating to gallbladder type pain in their triage, but never after that. So the Isbicki has nothing to do with symptoms that would be indicative of biliary colic. So they're just asked if they're having abdominal pain. So if they're developed a kidney stone and they're having completely unrelated abdominal pain afterwards, they're going to get counted as having abdominal pain. So I think judging with that, the pain score that they used afterwards is tricky because it's hard to know how many of these patients are really having the same type of pain that they had ahead of time.
Yeah, I think that's a real concern also. Any insight, James, in your deep read into the methods about why they changed the pain rating scale? I mean, we get the sense that the Isbicki probably may have been an inferior way of assessing. So what caused them to change? Do you think that was a good choice?
I'm not entirely sure. I admit they describe a little bit that they did this on consensus for the 5-year follow-up. I don't really know why. One thing that was interesting though, I mean, it's a little bit more of a easy to use scale that kind of captures like the subjective nature of somebody's experience with pain. An interesting thing that is almost just a side note, and I don't think changes the interpretation at all, was that the per protocol analysis of the 5-year follow-up, which was using the visual analog scale, was actually like significant for non-inferiority. That's just a thing. It doesn't really change how you interpret it because that's also probably the least useful kind of analysis to look at. And at the end of the day, I think I really like Kim's framing this as like, to a certain degree, people are practicing restrictive cholecystectomy anyways. And I agree that a key takeaway is that, there really was a pretty minimal difference in the number of patients that had surgery. I'm strangely fascinated by how, despite randomization, there were still more patients in the restrictive strategy that had fulfillment of all the criteria. So like if they're really like I'd love to kind of try to figure out why that would be. If patients are just hitting the clinic for the first time and they're randomized, I don't know why that would be different. So that's interesting, I thought.
Yeah, I agree. I mean, my interpretation of that is they were very broad in the setting of abdominal pain. I think there was probably an opportunity to screen the abdominal pain. This is real world, right? How many patients do you see in your clinic who have abdominal pain that in no way, shape, or form relates to their gallbladder as far as you can tell, but they're coming to you because somebody did an ultrasound and found a gallstone, right? So I think that's very reflective of the real world, and I would bet it's chance alone. But had they screened a little better for some of the symptoms in advance of enrolling and randomizing these patients, I bet you would absolutely look, maybe do a little bit better from that perspective. We have another question that's come through. I'll just ask it in a second here. But as I'm doing that, I would direct everybody to the chat to make sure you pick up that attendance form so that you can get your CME credits. It's in the chat for you to link there. And the question that came through is, has anyone looked at the negative predictive value of the criteria, coming up with a score for a likelihood of pain relief? You guys have dove deeper into the literature, or maybe in your experience, what can you share with us?
So the SECURE trial did publish, based on their data, which factors, and I had showed that on one of my slides, which factors were most predictive of relief. So, and again, there's cohort studies that do the same thing, but there's no accepted, validated score that we have. I think it's like, you know, when I was reading this study, I was picturing somebody with right-sided renal colic who could easily answer yes to all 5 of those questions, right? But I would hope that a general surgeon would know the difference between renal colic and cholecystectomy. So I think, you know, the problem is that the criteria that they're using, like, what are they actually asking, right? Whereas the Seagull study, why I think that's really interesting, is they're really saying, no, we think you have biliary colic, but we're not going to operate on you. And are you any worse or better off? Whereas this study, I'm not sure what they're trying, like, are they trying to say that these criteria are better than a surgeon at choosing if it's biliary colic or not? Are they trying to say that this is going to avoid cholecystectomy? It really didn't, not significantly so. So it's just kind of an interesting thing to look at. But I think, you know, at some point, AI is probably going to do better at us than predicting whether or not somebody truly has biliary colic or not. I don't think this score does that, but I suspect at some point that will be doable. There will be a way that it can be done better than a surgeon's gestalt.
Yeah, and awesome that a comment, the positive Murphy's is probably my hang your hat on criterion. I love that. I'm going to turn it over to Dr. Ball for the last question.
Well, thanks, Kelly, and thanks to all the panelists for such a beautiful job. I feel like, having spent the day in clinic today, that I saw all of these patients just today alone. And, you know, I always find it humbling when we look at really any topic within our chosen surgical subspecialty or specialty, and we're sort of failing, or at least inaccurate, making the wrong decision up to a third of the time. I think we really have to look at ourselves and really think about what we're doing in the context of this kind of data. I'm curious, and I'd love to hear, you know, Sean's point of view first, and just taking it out a little bit further from Sean's clinic tomorrow and mine from today. Sean and Kim and James, how often do you guys then apply, say, a HIDA scan, or what other tests are you using for that group of patients where you're just not quote unquote sure?
Yeah, no, that is the perfect question, Chad, because, you know, where you'd love to take this paper is to create some algorithmic approach that, you know, lands patients into 2 pots. Physical exam is by far my most useful tool. And so, you know, the diagnoses that I'm trying to work through that I think are common masqueraders would include gastritis and GERD. And I do find central tenderness is present for a lot of those patients, and it would tip me off. Costochondritis, I do find pretty commonly, and it's often a cause of non-resolution of pain, where patients get referred back and they still have pain, and you examine, and they really have focal tenderness over those rib joints. I don't know if that's related to where the port sat, or if it was present before and just maybe an incorrect diagnosis, or 2 synchronous diagnoses, but that's certainly one I think a lot about. And even in history, if they mention mechanical symptoms like, oh, it hurts when I touch my shoe, or I can't sleep on my right side, those are cues to me that this is not biliary colic. This is going to be something MSK. And so those would all direct my investigations. I love a trial of PPI, and that is certainly something I can do for people while they're on my wait list, and see if I can get them off my wait list. So a lot of people will have come with a trial of PPI, or maybe even tried at home some Tums or Gaviscon, and if you don't ask about it, you won't know, but often that information's there if you ask. But that is a quick way to not get a cholecystectomy in my clinic, is to be responsive to antacid. A HIDA scan, I would say that is a pretty select circumstance, right? So that may be for a patient that has no stones, but has classic symptoms, and they've been referred with an ultrasound. And certainly for those patients, I always first consider that ultrasound's not perfect and it can miss stones. I consider that people can pass stones. And sometimes before I send them to a HIDA scan, I really think to myself, what am I ordering this for, right? Am I hoping it's going to be normal so I can send them on their way, or am I hoping I'm going to find something, or am I going to end up with like a normal HIDA and still want to take out their gallbladder for some reason, you know? And so I would say it's a rare event for me to order a HIDA scan, but I do it. It has a role.
Last comments to Kim and James on that.
Yeah, I guess as an HPV surgeon, I think Chad probably can sympathize with this. I think I've become an expert in telling patients your right upper quadrant pain is not caused by X. So I'm quite comfortable telling people when I don't think it's caused by their gallbladder. I mean, we see patients all the time with hemangiomas or small hepatic cysts that have symptoms that are almost certainly MSK in nature, and they get sent through because of some incidental finding. So I've gotten pretty comfortable with telling patients that I really don't think I'm going to help you with taking out your gallbladder and leaving it at that. I try really hard not to order a HIDA scan. I think that they more often add more questions than answers. We're seeing all sorts of patients that are talking about gallbladder hyperreflexia now. And so you have to be careful ordering the test if you don't really want to know what the symptoms are. I, like Sean, will sometimes use it in patients with really classical biliary colic type symptoms that don't have stones on ultrasound. And if I'm doing that, and I can literally count on one hand the amount of times I've ordered a HIDA scan for that purpose, or at all, to be honest, I always ask for the CCK. And what I'm most interested in is was the pain reproducible with CCK? So yeah, I rarely order a HIDA scan. Unfortunately, people get sent to me for second opinions that have had HIDA scans more frequently than that, but I try to stay away from them.
Yeah, and I'll also say, like, I think thinking about the HIDA scan thing, I rarely have used HIDA in an outpatient setting. I can think of all the reasons why I would use it in an inpatient setting to try to differentiate whether or not something is, primary biliary versus a secondary phenomenon. And I think I've only ordered a HIDA once in an outpatient clinic for a patient with really atypical things where I was trying to sort of, really see to what degree is this their gallbladder. But it's not even really on an algorithm for me, I think.
Excellent use of resources by everybody. That brings us to the end of our session tonight. I really want to take the opportunity to thank our tremendous panelists for a great discussion around, I think, controversial paper. I certainly remember when the first one came out, it was controversial, and the take-home message is probably we underestimate our value as surgeons, in my opinion, in terms of making these decisions. So thank you to our panelists for their clinical insight and also for a review of a great paper, and to my co-host, Dr. Ball, and to our EBRS team. Please remember to complete your forms for your CME credit, and we look forward to seeing you next time. Have a good night, everybody. Thanks again.